much better. Am I audible?
Yes, ma'am. Please go ahead.
Okay. A very good evening, everyone. I'm Dr. Tejaswini Vaid. I'm the Associate Consultant in the Department of Medical Oncology and Hemato-Oncology at Medanta, Gurgaon. And it's my pleasure to welcome you all to today's CME, where we will be discussing some of the recent advancements in the management of lymphoma and myeloma. I'd like to begin with introducing to you the organizing team. We have with us Dr. Ashok Vaid, who's the Chairman of Medical Oncology and Hematology at Medanta, Gurgaon, and Dr. Nitin Sood, who's the Director of Hemato-Oncology and Bone Marrow Transplantation at Medanta, Gurgaon. I'd request Dr. Ashok Vaid to give some opening remarks.
Good evening, everyone. Thank you, Tejaswini. And a very warm welcome to everyone who's found time to join us this evening. We have a very interesting program where the young trainees would be presenting some of the abstracts, and they would be discussed. All these abstracts would be discussed by some of the consultants, some of the senior guys, and followed by a panel discussion. And I have my thanks to all the people, all the team at Medanta who have energized this program, and the moderators, panelists, and last but not the least is the Intas Pharma, who have actually conceptualized the program and also helped us in executing the program. I have my special thanks to all the panelists, all the senior faculty who have joined today, and to Rajesh from Mice Ideas for spreading the information around. We have 204 joinees today, and there are 33 people from 17 different countries who have actually registered the program, ranging from Australia to UK. And with that, I actually would like to stop here and invite Dr. Nitin Sood to offer his opening remarks. He's the program director this evening. Over to you, Nitin. Are you there, Nitin? So I think by the time till he joins in, Nitin, could you hear me? Could somebody confirm if Dr. Nitin is joined?
Dr. Nitin has joined, sir. Dr. Nitin?
Sorry. I'd actually joined as a viewer. So, but I hope you can hear me now.
Yeah, absolutely, very well. Over to you, Nitin, for your comments and your opening remarks. Thank you so much.
Sir, thank you so much for your opening remarks. And we've got a lovely conference today, studies on lymphoma and myeloma. And since we are a small group, I think we can all interact very well on this. I hope this gives you lots of networking opportunities. We've got several abstracts, and I want to invite our first speaker so that we can get started straight away. I'll ask the audience to put their questions in the chat box if they have any, or if they have any questions, just raise their hand so that we can address the questions. So over to Dr. Swaminathan, who's going to be our first speaker.
Good evening, everybody. Can I share my screen?
Sure, ma'am.
Am I visible? Is my screen visible?
Yes, ma'am.
Yeah, we can see your screen.
Okay. Good evening, everyone. I will be presenting two abstracts. The first one is the Alpine trial, the final analysis of zanubrutinib versus ibrutinib in patients with relapsed refractory CLL and SLL. Sorry, is my slides moving?
Just click on the slide and try to move.
Okay, sorry. Yeah. So Bruton tyrosine kinase is a key component of B-cell antigen receptor signaling pathway necessary for tumor cell proliferation in CLL and B-cell lymphomas. We know that ibrutinib is a first-generation BTK inhibitor. At present, it's a standard FDA-approved treatment option for untreated as well as relapsed refractory CLL patients. One of the major holdups in using ibrutinib is significant adverse effects in a population of patients like hemorrhage, atrial fibrillation, arrhythmias, and hypertension. And it's likely that these adverse effects are due to off-target kinase inhibition of the drug. And studies have shown that anywhere between 16 and 23% of patients might have to discontinue ibrutinib therapy due to treatment-related adverse effects. So zanubrutinib is an irreversible next-generation BTK inhibitor. Zanubrutinib is more selective, has a more selective BTK inhibition action, and hence likely to have less off-target kinase activity. And phase 1, phase 2 studies have shown that zanubrutinib tends to demonstrate complete and sustained BTK occupancy in peripheral blood mononuclear and lymph node cells in CLL patients. So what was the rationale for this study? It was hypothesized that achieving complete BTK inhibition in blood and lymph nodes can provide meaningful and sustained response in CLL patients. And higher BTK inhibition selectivity might reduce toxicities due to off-target kinase inhibition. And higher and more complete BTK occupancy might maximize efficacy and potentially increasing the likelihood of achieving deep and sustained remission in CLL. And based on this rationale, investigators initiated a multicentric global open label phase 3 trial where they did a head-to-head comparison of zanubrutinib versus ibrutinib in patients with relapsed or refractory CLL. So the patient population in the study, where patients confirmed to have a diagnosis of CLL, meeting the International Working Group criteria, requiring treatment, who were relapsed or refractory to at least one previous line of therapy. They had to be more than 18 years of age and had to have some measurable disease by imaging at the time of treatment initiation. The intervention given was tablet zanubrutinib 160 milligram twice daily. The control arm received tablet ibrutinib 420 mg once daily. The primary outcome that the study was designed to was investigator-assessed overall response rate, which included complete response and partial response. In the final analysis, a key secondary endpoint that has been highlighted is the PFS. And the study was conducted between November 2018 and December 2020. So, like I said, it was a randomized open label phase 3 trial. Patients with relapsed refractory CLL who have received at least one previous line of systemic therapy with measurable residual disease by imaging, and they shouldn't have had a previous BTK inhibitor exposure. And these patients were stratified by age, China versus non-China, and refractory disease status and high-risk mutation status into two arms, receiving zanubrutinib or ibrutinib, and was followed up till progressive disease or planned to be followed up till progressive disease or unacceptable toxicity. Baseline traits seem fairly well matched. Patients, the bulk of patients having high-risk disease, IGHV unmutated status, complex karyotype, and bulky disease was not statistically significantly different in either of the arms. The primary endpoint, overall response rate, which included CR and PR rates. This table is actually from the interim analysis. You can see the numbers are slightly different from the total number of patients. In the interim analysis at 15.3 months of median follow-up, the overall response rate was significantly higher in the zanubrutinib arm as compared to the ibrutinib arm. And they also noted that when they looked at the subgroup of high-risk disease patients, this superior overall response rate seemed to be sustained. In the final analysis, again, the overall response rate in the zanubrutinib arm was higher, 86.2%, which included patients with PR and patients in CR, as compared to patients receiving the control arm, where patients were receiving ibrutinib. Secondary outcomes, Progression-free survival at 24 months was again by numbers better in the zanubrutinib arm, 78.4% at 24 months. And as compared to that, 65.9% of patients had progression-free survival at 24 months of follow-up in the ibrutinib arm. When they looked at the PFS benefit in various subgroup of patients, they noted that patients, irrespective of whether they had high-risk mutation like deletion 17p or TP53, IGHV, unmutated status or complex karyotype, the PFS benefit seemed to be favoring the zanubrutinib arm. Another secondary outcome that was assessed was overall survival. 24-month overall survival was actually more or less similar between both the groups. They also assessed the incidence of adverse events in both the arms. So when they looked at what percentage of patients had any adverse effect of any grade, almost 98 and 99% of patients in both arms tended to have some degree of adverse effects. However, when they looked at serious adverse effects, the absolute numbers tended to be higher in the ibrutinib arm, percentage-wise 50% in the ibrutinib versus 42% in the zanubrutinib arm. When they looked at what percentage of patients tended to have treatment interruption or discontinuation because of an adverse effect, again, the numbers were slightly higher in the ibrutinib arm. The percentage of patients who had to discontinue treatment because of an adverse effect was 22% in the ibrutinib arm compared to 15.4% in the zanubrutinib arm. And when they looked at what were these adverse effects, the listed adverse effects were seen in both the arms. The incidence of neutropenia by itself seemed to be, the frequency of neutropenia itself seemed to be higher in the zanubrutinib arm. However, when they looked at the incidence of grade 3 or more infections, where if this translated to that, that tended to be slightly higher in the ibrutinib arm as opposed to the zanubrutinib arm. And like I showed in the previous slide, the grade 3 neutropenia tended to be higher in the zanubrutinib arm. An important side effect is cardiac adverse events. So the rate of any degree of atrial flutter or fibrillation was significantly lower in the zanubrutinib arm. Percentage-wise, in the zanubrutinib arm, it was 5.2%, and in the ibrutinib arm, 13.3%, and this was statistically significant as well. When they looked at the profile of the cardiac adverse events, about 29.6% tend to have some cardiac adverse event in the ibrutinib arm, as opposed to 21% in the zanubrutinib arm. There were 6 fatal cardiac events in the ibrutinib arm, as opposed to none in the zanubrutinib arm. So the investigators' conclusions were, this is one of the first trials having a head-to-head comparison of 2 BTK inhibitors. And zanubrutinib has shown better overall response rates, including CR and PR, and progression-free survival in final analysis as compared to patients receiving ibrutinib in relapsed refractory CLL patients. And they looked at whether this benefit was sustained across high-risk disease patient, and this seems to be sustained across patients having high-risk disease. And zanubrutinib may potentially have a more favorable safety profile as compared to ibrutinib, with lesser number of patients having treatment discontinuation and fewer fatal cardiac events in the zanubrutinib arm. Should I go on to the next one?
Yes, ma'am.
Yes, please, Anusha, you can continue to the next one.
Okay. My screen is visible. Can I go ahead?
Yes, ma'am.
Yes, go ahead.
The second abstract that I will be summarizing is the Captivate trial. This is actually the 5-year follow-up of the undetectable MRD arm of the ibrutinib versus placebo randomization in patients who received ibrutinib and venetoclax as first-line therapy for CLL. So again, BTK inhibitors is a standard of care currently for CLL patients who require treatment. There have been preclinical and early clinical studies which seem to offer evidence that suggests that ibrutinib with venetoclax may have some synergistic activity, and more attractively, they seem to have non-overlapping toxicities. So Captivate was a randomized phase 2 study assessing the safety and efficacy of using ibrutinib and venetoclax combination as first-line therapy for patients with CLL. This study actually has two separate cohorts after a initial phase, where there's an MRD guided randomization cohort and there's a cohort of patients that go on to receive only fixed duration of therapy. So this was the study design. This is a multi-center randomized phase 2 study, and patients less than 70 years who were treatment naive for CLL, who had an indication for treatment, whose performance status was ECOG PS 0 or 1 only, were recruited, and a total of 164 patients were taken in. All patients had a lead-in phase where they received ibrutinib once daily for 3 cycles, each cycle of 28 days. And this was followed by a combination treatment phase, wherein the patients received ibrutinib once daily with venetoclax. Venetoclax dose was gradually ramped up to 400 mg once daily. This was continued for a total of 12 cycles, after which MRD guided randomization was then done. When the MRD reports were awaited, most patients went on to receive 1 or 2 more additional cycles of ibrutinib and venetoclax. So once an undetectable MRD was detected, diagnosed, they were then randomized into 2 arms, one arm of whom went on to receive continued ibrutinib therapy, and one arm of which essentially received only fixed duration treatment, meaning they received placebo in place of ibrutinib. So undetectable MRD after the ibrutinib venetoclax phase, which they defined as less than 10⁻⁻⁴ sensitivity by flow serially in peripheral blood and bone marrow for at least 3 cycles. Once by this definition, they had an undetectable MRD. Then these patients were randomized into 2 arms. The intervention arm received ibrutinib 420 milligrams once daily, and the control arm received just placebo, in essence receiving only the fixed duration of ibrutinib and venetoclax prior to this. And this abstract is the follow-up of this arm of trial.
Anisha, if you could just sort of hurry it up a little, and we'd like to stick to the time limit.
Okay, sure. So the baseline features were more or less similar. The absolute numbers were slightly higher in the ibrutinib arm having high-risk disease. The primary endpoint was 3-year disease-free survival. If you can see, the 3-year disease-free survival in both the arms was not statistically significantly different. It was 93% with the ibrutinib and 85% in the placebo arm. And the other way that they looked at it was the response achieved in the ibrutinib plus venetoclax combination fixed duration therapy was sustained in the placebo arm. 4-year progression-free survival. Again, this was not significantly different in patients who continue to receive ibrutinib or continue to receive just placebo. And they looked at high-risk subgroup of patients, and they found that this PFS benefit was still sustained. Another secondary outcome was 4-year overall survival. And there was just 1 death in the ibrutinib arm, and clearly this was not statistically significant, and there was no difference. Another important and secondary endpoint was percentage of patients achieving CR in different timeframes after randomization. And the increase in CR rates achievable was 12% in the placebo arm, 14% in patients who continue to receive ibrutinib. Again, this was not different in both the arms. They also looked at how many patients went on to sustain their MRD negativity. The randomization criteria was that they had to be MRD negative at baseline. So it was 100% at 1 year, 2 years, 3 years. Again, the percentage of patients sustaining MRD negativity was not different irrespective of whether they received placebo or ibrutinib. In post the ibrutinib venetoclax phase, the adverse events in this arm of trial was actually very uncommon. And when they occurred, they were similar in rates. There was just one event of atrial fibrillation in the ibrutinib arm, and there were no new grade 3 or more hemorrhagic events in any arm. So authors' conclusions were, so ibrutinib venetoclax is an all oral once daily chemotherapy-free regimen, and this seems to provide deep and durable responses in patients with CLL. And they concluded that undetectable MRD and 3-year disease-free survival, despite patients receiving just placebo, and this response seemed durable. This is a very encouraging sign in hoping for a potential treatment-free remission option that can provide sustained response in CLL patients.
Great. Thank you so much, Anusha. I now invite Dr. Pratibha Dhiman, who's a senior consultant in the Department of Medical and Hemato-Oncology at Medanta, to give her expert opinion on these two studies. Over to you, Dr. Pratibha.
Ma'am, we can't hear you properly.
We can't hear you, Dr. Pratibha. I think you may not be connected to audio. Yeah. I think we should be able to hear you.
Now, am I audible?
Yes,
Yeah,
yes,
we can hear you.
Oh, that's the case. Okay, fine. So thank you so much for the kind introduction, Dr. Tejaswini. And thank you, Dr. Anusha, for a very quick update about both the trials. So I will be addressing the Captivate trial first. As we know that BTK inhibitors are the new standard of care in the treatment of CLL. And they provide us the benefit of being an oral medicine and mobilizing the CLL cells from their protective niches to the peripheral blood, and an effective inhibition of the proliferation by stopping the B cell signaling. So the Captivate trial is actually kind of a complicated trial because it has two cohorts associated with it. So one had studied the fixed duration, and the other has studied the MRD analysis along with the drugs going on and when the patient is off the drugs. So as very well documented in the trial and presented by Dr. Anusha also, that there has been a benefit of PFS. The overall response rate is great. If you see that after the fixed duration of 15 months of therapy, the overall response is somewhere around 90 to 95% with a CR of 60 to 70%, which is great in CLL. And when they have randomized the patients according to the MRD, patients who are MRD negative, they were further randomized to ibrutinib versus placebo arm. So both the placebo and the ibrutinib arm fares well, and it is something around 95 versus 100% of the sustainability of the MRD, which remains throughout the 3 to 4 years follow-up. The other arm, which was not which will be answered, I suppose, in the subsequent chapter of this trial, is that the second arm, which was MRD detectable. So these patients are further randomized into ibrutinib versus ibrutinib plus venetoclax maintenance. So what this trial has showed us, first of all, both the drugs, both the medicines are available in India. So that is an exciting thing for us. The first thing which is very much concluded by this trial is the fixed duration. In CLL, giving an option of treatment-free remission to the patient, it highlights a lot about the clinical practice. Because at the end of the day, when you start your patient on a BTK inhibitor, the question remains that how long I have to take the drug. So when the answer is lifelong, then the enthusiasm actually subsides at the very moment. So the fixed duration is the first highlight, that despite the fixed duration treatment, the responses are deep, they are durable, and it's sustained over the 4 year of follow-up. So the MRD, which has the patients who achieved the MRD when they were off the drug, when they were in the placebo arm, the MRD remains sustainable. So that is the second point, that when we can offer this thing to the patient, that we can offer you a drug holiday without the fear of loss of the response. So second important thing. Third important thing is, of course, the safety profile, that the ibrutinib plus venetoclax combination, we have it a synergistic kind of a combination, because ibrutinib highlights or it activates the CLL cells so that they can be susceptible to the BCL2 inhibition. So that's a good point. The safety profile is not a question here. There were no safety alarms during the trial. The only thing which actually I find in this trial a little tricky was that although there is adequate representation of all the high-risk genomic groups of CLL, but still, if you see closely, the 17P arm patients, when they achieved MRD negativity, so most of the patients were actually randomized towards the ibrutinib arm. They were not mobilized towards the placebo arm. So in the 17P arm, I'm not too sure whether we can give this TFR kind of an offer to the patient, whether we should continue it for a longer period or not, because this arm certainly has a predilection, or maybe, I don't know whether it's a randomization bias or something, that most of the patients were eager to follow the ibrutinib arm rather than the placebo arm. But otherwise, combination of both the drugs, and considering that we have used ibrutinib first, and after the decrease of chances of TLS, we added venetoclax. So it's a very well-framed trial, and for sure it is to come in the practice. I suppose it can be the next standard of care for us. Now coming to the Alpine study. So in Alpine study, it's a phase 3 trial which has been conducted to see head-to-head activity of zanubrutinib, which is a second generation BTK inhibitor, versus ibrutinib. The overall responses are great in comparison to ibrutinib. Zanubrutinib fared well, and it fared well in both the arms, like in high-risk patients and in non-high-risk patients. So that's, I suppose that's very well answered in this trial itself. The other thing is the safety profile, that this drug is well tolerable. Patient didn't have any kind of cardiac events, though the neutropenia was there, but there were no emergency admissions because of febrile neutropenia. COVID was a little increased in this arm, but not sure about the statistical significance of this. But the tolerability is very good in comparison to ibrutinib. So as we know thoratically, that zanubrutinib is a drug which stays in the blood for a longer period. So it helps in constant killing, constant inhibition of the kinase, so that the constant killing of CLL cells can happen. So that indirectly transpires on the paper, on thoratically, that it has to be better efficacy drug than in comparison to ibrutinib. But I'm sorry, I will refraining myself by saying this, that I don't think that it is a better efficacy drug. It is a better tolerated drug. Because if you see this trial, the dropouts or the discontinuation in the ibrutinib arm was actually double in comparison to the zanubrutinib arm. So just because the patient has discontinued the drug, so maybe that has contributed to the better PFS or better overall response. That can be, I think that can be partially challenged in this trial. The second thing is the follow-up. A follow-up of 2 years, I think that doesn't stand much of a ground in CLL. It will be too early to say that it has a better efficacy. But no doubt, whenever this drug is available in India, it will be the changing phase of CLL because of the side effects. And in comparison to acalabrutinib, as we know that acal has a disadvantage of interaction with the most common drug which we use, in our clinics, that pantoprazole. So, and this drug doesn't have any interaction like that. So if I have to be in the clinic and prescribe a drug for which the patient is ready, then between acal and zanubrutinib, I think zanubrutinib will definitely win the race. So I think both the trials are well presented and very well executed also when the investigators got through that. Thank you.
Thank you so much, Dr. Pratibha. I couldn't agree with you more. That BTK inhibitors, they've completely changed the way we treat CLL, and if we can give a fixed duration therapy, there's nothing like it. There's a question in the from the audience: why adverse events are more in ibrutinib than as compared to zanubrutinib? Dr. Pratibha, would you like to take it?
I suppose the reason being that the off-target, it's a completely targeted therapy, like a targeted BTK inhibitor in comparison to the ibrutinib. So therefore, the off-target inhibitions are less, the other kinases inhibitions are less. So therefore, maybe the side effect profile is better.
Right. Thank you so much. I now invite Dr. Narayan Adhikari, who's currently pursuing his DNB in medical oncology at Vedanta, to present the next two studies. And I request all the presenters and experts to stick to the time limit. Thank you so much. Narayan, you can take it from here.
Thank you, ma'am, for your kind introduction. Today, I'll be presenting two abstracts. First is the matrix trial of International Extranodal Lymphoma Study Group. It was phase 3 trial of high-dose chemotherapy followed by autologous stem cell transplant versus non-myeloablative chemoimmunotherapy as consolidation for primary central nervous system lymphoma. So, as you know, primary central nervous system lymphoma is aggressive form of non-Hodgkin's lymphoma, which is treated with high-dose methotrexate-based induction polychemoimmunotherapy. The optimal consolidation is debated, and modalities like whole brain radiotherapy, combination chemoimmunotherapy, high-dose chemotherapy followed by autologous stem cell transplant are studied. There are multiple issues with treating primary CNS lymphoma, like blood-brain barrier, brain tissue vulnerability to treatment modalities, cross-resistance of drugs, poor salvage strategies and outcomes. So, in a matrix phase 2 trial, there was addition of thiotepa and rituximab to standard methotrexate and cytarabine, which was popularly called matrix regimen, and it improved response and survival in phase 2 IESLG 32 trial. Although the survival outcomes with autologous stem cell transplant and whole brain radiotherapy were similar in the phase 2 study, whole brain radiotherapy was associated with long-term neurocognitive decline with impacts on quality of life. So ASCT was standard of care in young fit patients. Current study compared high-dose chemotherapy followed by autologous stem cell transplant versus non-myeloablative chemoimmunotherapy as a consolidation regimen for primary CNS lymphoma. So 346 immunocompetent HIV negative patients with newly diagnosed primary CNS lymphoma between 18 to 65 years age or 66 to 70 years with ECOG performance status of 2 or less received induction chemoimmunotherapy with a matrix regimen, and those achieving at least CR or PR were randomized in 1:1 randomization to consolidation with high-dose chemoimmunotherapy followed by autologous stem cell transplant versus non-myeloablative chemoimmunotherapy with RDEVIC regimen for 2 cycles. It was a multi-center randomized open-label phase 3 trial. The primary endpoint was progression-free survival, and the secondary endpoints were complete response rate, overall survival, quality of life study, and safety analysis. The baseline characteristics were well matched between the 2 arms, and there was no significant difference between them. As per the response outcomes, the complete response rates were almost similar in both the arms, which was almost 40% before consolidation and 67.5% after consolidation in autologous stem cell arm and 65.2% in chemoimmunotherapy arm. But 3-year progression-free survival was significantly higher, with 79% in ASCT arm versus 53% in RDEVIC arm, with hazard ratio of 0.4 favoring the ASCT arm. Similarly, 3-year overall survival rate was also significantly higher, of 86% in ASCT arm when compared with 71% of RDEVIC arm, and the hazard ratio was 0.45%, again favoring the ASCT arm. These are the Kaplan-Meier survival curves comparing the outcomes, which showed ASCT did significantly better when compared with polychemoimmunotherapy arm. Grade 3 toxicities were numerically higher in ASCT arm, but the neurocognitive outcomes were not different. So consolidation with high-dose chemoimmunotherapy followed by autologous stem cell transplant results in significantly better outcome than non-myeloablative chemoimmunotherapy. This comes along without any measurable negative impact on neurocognitive functions, and there was excellent risk to benefit ratio. So high-dose chemotherapy followed by autologous stem cell transplant is the standard consolidation therapy for fit patients of primary central nervous system lymphoma. Now coming to my second study, which was a phase 3 triangle trial. It was a landmark trial of European mantle cell lymphoma group. It was phase 3 trial of ibrutinib with chemoimmunotherapy with or without autologous stem cell transplant versus chemoimmunotherapy followed by autologous stem cell transplant, which is current standard in young patients with previously untreated mantle cell lymphoma. High-dose chemoimmunotherapy followed by autologous stem cell transplant and rituximab maintenance is current standard of care for young patients with mantle cell lymphoma. Ibrutinib has shown promising efficacy in both previously untreated older patients as well as the relapsed patients of mantle cell lymphoma. European MCL Network phase 3 triangle trial is evaluating ibrutinib with chemoimmunotherapy with or without autologous stem cell transplant versus standard chemoimmunotherapy followed by autologous stem cell transplant in previously untreated younger patients. And the current study showed the analysis of safety and efficacy data from this phase 3 triangle trial. 870 patients with previously untreated stage 2 to 4 mantle cell lymphoma aged less than 65 years who were suitable for high-dose cytarabine-based chemotherapy and ASCT and ECOG performance status of 0 to 2 were randomized to 3 arms. First arm was arm A plus I, which consisted of chemoimmunotherapy with rituximab and R-CHOP alternating with rituximab and R-DHAP along with ibrutinib followed by autologous stem cell transplant, followed by 2 years of ibrutinib maintenance. The arm I was chemoimmunotherapy, R-CHOP alternating with R-DHAP with ibrutinib, and there was no ASCT and 3 years of ibrutinib maintenance. And the third arm was ASCT arm, which consists of standard chemoimmunotherapy, R-CHOP alternating with R-DHAP for 3 cycles, followed by ASCT, followed by observation. Rituximab maintenance was added according to the national guidelines in all 3 arms, and it was almost similar in all the 3 arms of 57, 54, and 58%. It was also
Dr. Narayan, I think, yeah.
Seems to have lost the network.
Right, and I think he's back again. Dr. Narayan, can you hear us? You're not.
Why don't we have a discussion on the
Can
first?
you hear us?
Nitin, could we have a discussion on the first abstract? By the time.
Yeah.
We have
let's-
What do you say?
Dr. Chirag Shah with us. I request Dr. Chirag Shah, who's the director in the Department of Hemato-Oncology and Stem Cell Transplantation, Apollo, Ahmedabad, to give his expert opinion on the first study.
Right. So I think the first study is a very important study because in the primary CNS lymphoma, we have never had such a large randomized trial with good follow-up. And also this tells us that there is one regimen that can be followed because earlier there are almost 3-4 different regimens which everybody is doing according to whatever they are used to with no direct comparison also, and they're all small studies. So first, this establishes matrix regimen as one important regimen to treat. Second, it tells us that in fairly older patients also this regimen is doable, and the entry criteria for less than 65, the fitness was not much of a criteria. So that tells us that if we treat these people with specific treatment, there we can improve their fitness and actually treat them rather than not go for the aggressive treatment. The results, of course, are as we would all like in the field of hemato-oncology, with a standard, gold standard randomized trial, 15% higher overall survival at 3 years, 71 versus 86%, and that is very good. However, I would like to caution that this is not for everybody because 25% of patients could not complete the treatment. So some kind of discretion and comfort with this regimen would be required for us to develop rather than jump for everyone to this regimen. But when it is possible and can be followed by transplant, it is the gold standard. And I think this also tells us that, including my own practice, that I think more of these patients need to be considered for transplant, which traditionally we have been, I think, less aggressive about in the primary CNS lymphoma. Thank you.
Thank you so much, Dr. Shah. I just want to ask Narayan, have you joined back?
Dr. Narayan, are you ready to present?
Yes, ma'am.
Great.
Please share
Just
your
continue from where you left.
Okay. Am I visible?
Yes, sir.
Okay.
Yeah, we can hear you.
Okay. So 3-year failure-free survival was 72% in.
Narayan, you'll have to share your slides.
Okay. Okay.
Yes.
So
Yeah.
3-year failure-free survival in ASCT arm was 72%. It was 88% in ASCT plus ibrutinib arm, and it was 86% in ibrutinib arm. Similarly, 3-year overall survival was 86% in ASCT arm, 91% in ASCT plus ibrutinib arm, and 92% in ibrutinib arm. So this was basically a superiority trial with two null hypotheses. First one was current standard ASCT is superior to the ibrutinib arm, which but the study could not prove the superiority of ASCT over ibrutinib. In fact, the 3-year FFS was significant, was 86%, which was numerically higher than 72% of the ASCT arm. So ASCT, standard ASCT is not superior to ibrutinib. The second null hypothesis was ASCT plus ibrutinib is superior to ASCT arm. So the study showed the superiority of ASCT plus ibrutinib over ASCT alone, with 3-year FFS rate of 88% in ASCT plus ibrutinib versus only 72% in the ASCT arm. The grade 3 to 5 adverse events in the induction protocol were similar between ibrutinib containing arms and those without the ibrutinib. Similarly, the grade 3 to 5 adverse events during ASCT phase was also almost similar between ibrutinib containing arm and the arm without ibrutinib. But grade 3 to 5 adverse events were significantly higher, mainly the hematological ones during the maintenance phase in ASCT plus ibrutinib versus ASCT alone or ibrutinib alone arm. So to conclude, addition of ibrutinib to standard chemoimmunotherapy with or without autologous stem cell transplant yielded strong efficacy and acceptable safety in younger patients with previously untreated mantle cell lymphoma. Autologous stem cell transplant plus ibrutinib is superior to autologous stem cell transplant standard of care arm, and ASCT standard of care arm is not superior to ibrutinib without ASCT based on the primary endpoint of efficacy. No conclusion yet as to whether ASCT adds to ibrutinib, but safety profile favors ibrutinib only arm. Numerical OS benefit observed in ibrutinib containing arm versus control arm, but data are immature. So this trial had opened new doors that maybe ASCT can be avoided from the treatment paradigm of mantle cell lymphoma altogether with use of ibrutinib, which has to be proven in a non-inferior or equivalence trial in further studies. With this, I'd like to conclude my second study.
Thank you so much, Dr. Narayan. Dr. Shah, we'd like to hear your comments on whether you think this study is practice changing and what you think about it in the Indian context.
Right. So I think this is opposite of the first study where the transplant was confirmed as important. Here the transplant role is being questioned. And with the data that we have, I think this is certainly very important. Whether I would say it is absolutely practice changing, probably not yet, because the overall survival data is still not mature. And there is a potential concern that the ibrutinib is for about 2 years. So what happens when you stop the ibrutinib? Also, the failure-free survival is not the most used parameter to determine superiority. So unlike PFS and OS, so that is one concern. But I think going forward, the questions that would come up are whether we can replace ibrutinib with the second generation BTK inhibitor, because the concerns remain with ibrutinib with some of the early deaths, and using it with R-CHOP are the although in this trial it seemed safe with no added toxicities, but that would need to be seen in the practice in the routine use. And the other question would be whether we need even any form of chemotherapy. Can we just do BTK inhibitor? Maybe with some patients who have very bulky disease may need some chemotherapy. So that would be an additional question I'm sure will be answered in the future. Thank you.
Thank you so much, Dr. Shah, for your opinion. I now request Dr. Abhishek Srivastav, who's pursuing his DNB in medical oncology at Medanta, Gurgaon, to present the next two abstracts. Abhishek, can you hear us? Abhishek?
I think he has just logged out.
Oh, okay. I think there must be a connection issue here. Can we have...
Ma'am, he is joining.
Okay, great. Okay.
Dr. Abhishek, please unmute.
Thank you for this opportunity, ma'am. Good evening, all. I am Dr. Abhishek Srivastav, resident medical oncology. So my first study is ma'am, give me a minute, please. I'm going to present the first study, extended follow-up results of pilot study of brentuximab vedotin and AVD in newly diagnosed early stage unfavorable risk CHL, classical Hodgkin's lymphoma using baseline MTV metabolic tumor volume and PET2 evaluation. The initial study was conducted in the year 2013 June to June 2019. Now this is extended version of this. According to Momotov and Mohti, most of the patients of early stage CL classical Hodgkin's lymphoma can be cured with combined modality therapy or petareprate approaches. It is found that those patients with bulky disease are at higher risk of relapse. Previous results from multi-center pilot trial of brentuximab vedotin plus AVD in newly diagnosed early stage unfavorable risk classical Hodgkin's lymphoma were reported showing promising efficacy and manageable toxicity. So this current analysis reports extended results from this trial and prognostic evaluation of baseline MTV in PET2. It was a multi-center, multi-cohort open-label pilot study in which patients of age 18 to 60 years previously untreated stage 1 and stage 2 unfavorable risk classical Hodgkin's lymphoma were included. A total of 117 patients were included in the study. They were planned for 2 cycles of brentuximab plus AVD, followed by PET-CT scan, followed by 2 more cycles of brentuximab plus AVD, followed by PET-CT scan. And after 4 PET-CT scan, they were divided in 2 groups, those who were negative PET and those who have positive PET. Those who had negative PET were enrolled in 4 sequential cohorts of radiotherapy. In the first cohort, 30 gray ISRT involved site radiotherapy was given. For cohort 2, 20 gray ISRT was planned. For 3, Cohort 3, 30 gray conventional volume RT was planned, and for fourth group, no RT was given. And those who are PET positive, they were sent for biopsy. If it was found positive, they were excluded from the study. And if negative, they were included in the radiotherapy trial. The primary endpoint was pulmonary toxicity and complete response. And the secondary endpoint was prognostic significance. These are the baseline characteristics. Overall, the median age is 32 years. 50% of our patients were male. The unfavorable features were MSK, a bulk of more than 7 centimeter, traditional bulk of 10 centimeter, elevated ESR, presence of B symptoms, presence of extranodal sites, involvement of more than 2 sites, and infradiabetic disease. This is the Kaplan-Meier curve showing PFS of all the 4 cohorts. Initially, it was of 2-year PFS. Now, the extended version is of 4 years PFS. So in cohort 4, when no radiotherapy was given, the results are comparable in all the 3 groups, approximately 90%. So it is concluded that radiotherapy can be omitted in these treatment protocols. These are the curves showing the PFS by metabolic tumor volume. Those who have low volume have a PFS of 100% as compared to those who have high, 91%. Similarly, for the PET scan assessment, those who have PET negative after two cycles have a PFS of 95%, whereas those who are positive have a PFS of 79%. This is a combined of assessment of MTB and PET2 scans, with those with low MTB and PET negative have a PFS of 100%, whereas those with high MTB and PET positive have a PFS of 60%. So after 4 years, a total of 4 patients were experiencing progressive events. They were managed with salvage therapy and autologous stem cell transplant. So the conclusion of the study is, with extended follow-up of 4 years, short course BV plus AVD remains highly active in early stage unfavorable risk classical Hodgkin's disease. MTB and PET results at baseline were significantly correlated with PFS. Combination of MTB and PET2 assessment identified patients with disease at high risk of progression. According to researchers, further investigations to short course BV plus AVD treatment using MTB PET adapted strategy is essential. This is the first. Shall I go with the second study, ma'am, or?
Yes, go ahead.
Yes, please.
So the second study is the pooled analysis of phase ED sequence MRD negativity assessment as surrogate endpoint after frontline induction therapy in patients with DLBCL. This phase ED means the phase variant enrichment and detection sequencing. It uses multiple somatic mutations in individual DNA fragments to improve sensitivity of ctDNA detection. It allows detection of DNA in ppm range in particular samples, and it enhances specificity by requiring concordant detection of 2 or more distinct mutations in a single DNA molecule. So previously available methods for ctDNA detection in plasma have lacked adequate sensitivity to detect MRD at the end of treatment below 10 to the power -4 cell-free DNA molecules. Phase variant enrichment and ctDNA detection via phase ED has shown to improve detection of ctDNA in patients with DLBCL after 2 cycles of therapy. So this analysis of pooled data from 5 clinical trials assess utility of phase ED sequence to detect molecular disease burden at end of treatment in patients with DLBCL who has received frontline induction therapy. In this study population, they have taken sample from 5 prospective large DLBCL trials in which 112 patients were included and 290 samples were collected. These 5 studies were the phase 2 study of acalabrutinib in RDI epoch or RCHOP or for patients with untreated diffuse large B-cell lymphoma. Second was clinical and pathological studies in non-Hodgkin's lymphoma and Hodgkin's disease. Third was phase 1-2 study of lenalidomide and obinutuzumab with CHOP for diffuse large B-cell lymphoma. Fourth was a phase 1 trial, polatuzumab vedotin with combination therapy for the treatment of untreated aggressive large B-cell lymphoma. And the last one, phase B study to assess safety and preliminary efficacy of tafasitamab or tafasitamab plus lenalidomide in addition to RCHOP in patients with newly diagnosed DLBCL. The study objective was to assess PFS, prognostic value of ctDNA MRD status taken during therapy and at end of treatment, and was analyzed by phase ED sequence at 2 different sites. Phase variants identified from pre-treatment tumor, plasma or peripheral blood mononuclear cells, and MRD was assessed at day 1 of cycle 2, 3, 4 and at end of treatment. ctDNA MRD results were compared with predictive values of CT scans for assigning remission. These are the baseline characteristics: 39% per female, median age was 61. The subtypes included were DLBCL GCB, most commonly 54%, followed by non-GCB, 25%, high-grade B-cell lymphomas, double hit, and primary mediastinal B-cell lymphomas. So the samples were assessed for ctDNA MRD status. Baseline 80 samples were collected, and that was increased to end of treatment up to 93. A total of 112 patients were assessed, and out of these, 97 successfully underwent genotyping for plasma or tumor tissue. So it is found that the rate of MRD negativity is increased over time in patients without PSA events. Initially, it was 24% at cycle 2, and it increased to 91% at end of treatment. So on treatment and end of treatment MRD disease positive detection for dissection by phase ED sequence was strongly associated with outcomes using Cox multivariable models. It is found that undetected ctDNA within 3 cycles is strongly prognostic of PFS, whereas persistent ctDNA MRD positive at end of treatment is highly suggestive of disease recurrence. Those were classified in high risk group. So with median follow-up of 17 months, 99% of patients with MRD negativity at end of treatment remain free of disease progression. ctDNA detection is strongly associated with outcomes in multivariate models controlled for clinical study and testing sites. End of phase ED sequence and PET were prognostic of PFS, but phase ED sequence predominates as it has more sensitivity. Phase ED sequence detected were DNA detected versus not detected at end of treatment significantly it certified PFS among patients in PET CR. So the conclusions in the study are: in the patient with DLBCL, phase ED sequence ctDNA assessment was strongly prognostic of outcomes, a stronger predictive value observed for MRD status at end of treatment. The detection limit is 10 to the power -6. MRD detection at end of treatment has potential role as surrogate endpoint within clinical trials and may enhance response criteria. Researchers have arrived at the conclusion that prospective plasma collection at baseline, during treatment, and at end of treatment is necessary in clinical studies of DLBCL to check for MRD. This is a conclusion.
Thank you so much, Dr. Abhishek. Two very interesting abstracts. I now request Dr. Prantha Chakrabarti, who's the Director of Hematology and BMT at AMRI Hospital, Kolkata, to give his expert opinion.
Yeah, I think before giving any opinion, because I am not an expert on this technology of looking at MRD by ctDNA, but the first one, Dr. Abhishek, you talked about looking at the tumor volume. So is that a standard protocol which can be directly translated to a clinical practice now? Because, we usually do PET-CT after 2 cycles, but when you're talking of MPV, is there a standard protocol of looking at that and then assessing it? Because you said it has an important impact, and especially if you're using short-term brentuximab-based therapy. So how do you do the MPV?
Actually, for clinical purposes, it is not used because the consensus on the optimal method for tumor segment of FDG images is not feasible all the time.
Okay.
This is the literature I found till now. So it is not clinically used, but it is mentioned that it can be used for further purposes.
Yeah, I think till it is standardized, we will not be able to incorporate it in clinical practice. Because the problem happens sometimes is when you only use PET-CT, and this was a study shown by our lymphoma registry led by Professor Veena Nair, that sometimes we are under-treating our patients and later on they're coming with relapse. So I think that has to be standardized. And for the second one, again, how clinically or, as a standard of care, is this ctDNA method feasible? Looking at MRD from your second abstract.
So this is what is shown here, that the phasic sequences, either algebraic or geometric or quadrantic, the MRD with 10 to the power -6 has a better baseline assessment.
Yeah, but is it done? Is it done in routine care, or is it just being done as on a trial basis? And is it feasible to do it?
So for now, it is basically used for clinical trials and maybe in future it can be used on routine basis.
Okay, okay. So those were my two questions. I think others can ask questions to him before we move to the panel discussion.
Are there any questions from the audience?
Yeah.
No,
Will
ma'am.
they come in the
Not
chat
that
box?
particular presentation.
Dr.
Okay,
Chakraborty, we
okay.
don't currently have any questions from the audience.
Okay,
We'll move on.
okay.
Shall we move on to the next segment
Yeah,
in that case?
please, please.
Thank you so much.
Thank you.
So I now invite Dr. Anjali Sachan to present the abstracts on multiple myeloma. Dr. Anjali, she's a DNB resident currently in the Department of Medical Oncology at Medanta, Gurgaon. Over to you, Dr. Anjali. Anjali, can you hear us?
Dr. Anjali, please unmute your lines.
Good evening, ma'am. Thank you, ma'am. Today I'll be presenting 2 slides.
Yes, we can see your slides.
Good evening, everybody. Today I'll be presenting 2 presentations. First is the IFM 2017-03 phase 3 trial of daratumab plus lenalidomide versus len and dex in frail patients with newly diagnosed multiple myeloma. The slides are not moving.
Ma'am, just click on the slide.
Just okay, thank you. So this was a randomized multicentric open labeled phase 3 trial who had randomized around 293 patients more than 65 years of age diagnosed with newly diagnosed multiple myeloma with IFM frailty score of more than equal to 2, which was calculated using age, ECOG-PS, and Charlson's comorbidity index. And they did a 2:1 randomization of their patients into the DR versus the RD arm. And treatment was given as per the standard doses, and treatment was continued in both the arms till disease progression or unacceptable toxicities. The primary endpoint of this study was progression-free survival, which has not yet been reported. I'll be discussing about the interim analysis done at 12 months of therapy with the endpoints of overall response rate, very good partial response rate, MRD negativity rates, and more than equal to grade 3 adverse events. So this slide basically shows that the baseline characteristics of in the 2 arms were comparable. And the response analysis, which was presented at a data cutoff of 12 months, and they showed that the overall response rate was better in the DR arm as compared to the RD arm. That was 96% versus 85%, and this was statistically significant. Also, the very good partial response rates were better with the DR arm rather than the RD arm. MRD negativity, which was assessed at 12 months of therapy, also showed that the rate of MRD negativity with Dara-Len was 10% as compared to Lendex alone, which was 3%. And this was also statistically significant. And this improvement in the very good partial response was sustained over time, as can be seen at 4 months, 8 months, and 12 months. Also, similar improvements in the rate of very good partial response with DARA was seen across all subgroups, including the IFM frailty scores and genetic subgroups, and there were fewer treatment discontinuation rates. So this slide shows the safety profile of the 2 arms. We can see that all grades, more than 3 adverse events, any grade, were more in the DARA arm. Be it also the hematological toxicities were more in the DARA arm, like neutropenia, anemia, but the rate of infections, and these differences were significant also. But the rate of infections, more than grade 3 or more infections, being the non-COVID infections or pneumonia, they were higher, slightly higher in the DEXA arm, the RD arm, but these was not statistically significant. Treatment discontinuation rates was also comparable between the two arms. So the investigators concluded that frail patients with newly diagnosed multiple myeloma, DR was found to be associated with higher response rates versus the RD arm. As we have seen, it was 96 versus 85%, and higher MRD negativity rates we had seen previously, 10% versus 3%. DR was associated with a favorable safety profile and no increased risk of infections or pneumonia versus the RD arm, although this data was not statistically significant. Treatment discontinuation rates were similar between the two arms. So the authors concluded that this is an encouraging result regarding the potential for a DEXA sparing strategy in frail patients with longer follow-ups are needed, and PFS analysis is still going on. My next study is, just give me a few minutes, ma'am. I'll just.
Sure.
The next abstract I'll be presenting is the Myeloma 11
Please
trial.
share your screen.
Okay. Next study is the Myeloma 11 trial, which is exploring the optimal duration of lenalidomide maintenance after autologous stem cell transplant. So this was again an open label randomized phase 3 study with 3 randomizations at the level of induction, intensification, and maintenance. Here we'll be talking about the results of the maintenance randomization with lenalidomide monotherapy versus observation. So this is the study design. They had included newly diagnosed symptomatic patients, transplant ineligible multiple myeloma patients who had successfully completed myeloma 11 induction protocols and underwent transplant. And they randomized the patients to receive lenalidomide 10 mg per day versus observation. And this therapy was continued till progression. The median follow-up was 44.7 months, and the median duration of lenalidomide therapy administered was 28 cycles. The endpoints of this interim analysis were overall progression-free survival, PFS2, and subgroup analysis of PFS with genetic risk subgroups and MRD status. So this slide is only about the basic baseline characteristics of between the two arms, which seems to be comparable. And this is the Kaplan-Meier survival curves of the PFS, which shows that lenalidomide in the PFS was 64 months, while in the observation arm it was only 32 months, and this was statistically significant. Statistically significant difference was also observed with progression-free survival 2 in the lenalidomide versus the observation arm. This slide shows the Kaplan-Meier curve analysis of progression-free survival. Assessed on the basis of genetic risk status, we can see that both in the standard risk and the ultra high risk or the high risk, there is benefit of giving lenalidomide over observation, and the difference is statistically significant in both. PFS maintenance, this is the Kaplan-Meier curve showing the PFS benefit with the MRD status. We can see the benefit is in the MRD negative arm, the median PFS is 59 versus 44 months in the observation arm, and which is statistically again significant. And in the MRD positive patients also, the lenalidomide arm had showed benefit in the progression-free survival, which was statistically significant. So this table shows the PFS or the PFS2 values, and it shows that with increasing years of lenalidomide administration, statistically significant difference between the lenalidomide therapy has been demonstrated up till 4 years in both median PFS and median PFS2. But beyond 4 years, we see that the difference between the two arms is not statistically significant. This table has two parts. The upper part of the table shows the benefit of median PFS by risk status. We can see that in the standard risk, the statistically significant benefit in the PFS was observed with LEN maintenance up to 3 years. And in ultra high risk or high risk up to 2 years. While the lower part of this table shows that median PFS in the MRD negative patients, statistically significant benefit could be demonstrated up to 2 years. But while in the MRD positive patients, the statistically significant difference has been demonstrated with lenalidomide maintenance even up to 4 years. Coming to the toxicity profile, we can see that with the increased or extended administration of lenalidomide, there was no worsening of bone marrow suppression, be it neutropenia or thrombocytopenia. So the authors concluded that continuing lenalidomide maintenance for up to 3 years have benefited patients with sustained MRD negativity, but beyond that, it is still unclear. While in MRD positive patients, results supports that continuing lenalidomide until disease progression. No evidence of cumulative hematological toxicities was observed even with long-term lenalidomide maintenance. However, additional data from other ongoing studies is still needed to determine the optimal duration of lenalidomide maintenance therapy. Thank you.
Thank you so much, Dr. Anjali. I now request Dr. Nitin Sood to give his expert opinion on the topic.
Yeah, thank you, Tejaswini and Anjali, very well presented. You've done two very important abstracts on myeloma. The first one's sort of looking at the optimal treatment for transplant ineligible patients, and not surprisingly, the arm which is added the anti-CD38 antibody has done better. So for the frail patients, for the not fit patients who are not fit for triple drug therapy in myeloma, Lendex sort of remains or was the standard at that point. More and more of us are using 3 drugs now. But the importance of that trial is that it's showing that we can omit steroids from first-line therapy in patients who are frail, really looking not great and not great candidates to have an infection. So Dara-Len has done better. The overall response rate was higher compared to the RD arm, significantly higher. The safety profile, more importantly, of Dara wasn't worse. And, the most common adverse events of cytopenias and infections and infusion-related reactions are there with Dara, but it's done very well in that category of patients. So there is a serious chance that Dara and Dara-Len may become the standard of care. Obviously, we need more data before we come to that conclusion. The next one you've done is the MRC Myeloma 11 trial, and not surprisingly, I mean, they've looked at LEN maintenance, but that question has been answered, to be honest, in the past. And that's what happens with MRC trials. They come up with big trials and they come up with evidence which is irrefutable, but it's a bit late. And sometimes it changes therapy, but I don't think this one's going to change the standard of care, which is LEN maintenance anyway after transplant. So after an auto, I mean, it's a huge number of patients. So the evidence is much stronger. Not surprisingly, LEN has done better than observation, which all of us now know. It's done better both in high risk and standard risk patients. And the benefit exists both in MRD positive and negative patients. I know we don't risk stratify patients by MRD as standard practice at the moment. But the good part is if you've got MRD positive disease after a transplant, then LEN the benefit is much stronger than compared to MRD negative patients. And more importantly, the toxicity is not worse. So you're not losing anything, you're gaining a lot, at least progression-free survival. And as you said, PFS2, which is an important marker of modification of the disease, sort of natural history of the disease by a drug, and it kind of the benefit exists in the second relapse as well. So Len remains the standard. It will remain the standard. It's just that we've got better evidence for it now. But I must say at this point that the bispecific antibodies are going to challenge that notion in the very near future, and watch that space for that. So thank you, Anjali, and over to Dr. Tejaswini.
Thank you so much, Dr. Nitin. We had a question from Dr. Shah in the audience regarding the dose of DEXA in the RD arm. I believe the dose of DEXA in the RD arm in the first study was 20 mg on day 1, 8, 15, 22, and 28. With this, we conclude the first session and we move on to the panel discussion. To moderate the panel discussion, I invite Dr. Aditya Jandial, who's a clinical hematologist at PGI Chandigarh. Over to you, Dr. Aditya. Dr. Aditya, I think your mic, yeah, you unmuted the mic, right?
Good evening, everyone. Am I audible and are my slides visible?
Yes, to both.
So, first of all, I sincerely thank Dr. Ashok Vaid and his wonderful team for giving me this opportunity to moderate this panel discussion session. And thank you, Dr. Sood and Dr. Anjali, for shifting the momentum back in favor of myeloma before we start this discussion. So it gives me great pleasure to introduce the honorable panelists for this panel discussion. We have Dr. Pratibha Dhiman from New Delhi, Dr. Chirag Shah from Ahmedabad, Dr. Ankit Rayani from Ahmedabad, and Dr. Prantar Chakravarti from Kolkata. Unfortunately, we do not have Dr. Mukul available with us today. So over next 30 minutes or so, I'll walk you down through two case scenarios, and the focus shall be to address some of the practical aspects or the questions that come up during the management of myeloma and lymphoma patients. So let's move on with the first case. So he's a 58-year-old gentleman, a businessman from Patiala, Punjab, and he presented with the complaints of low backache and fatigue for 3 months. And on evaluation, he was found to have anemia with hemoglobin of 8.1, normal serum creatinine, calcium, and LDH. There was AG reversal, and he underwent MRI LS spine with the spine screening that suggested T1 hypointense lesions in thoracic and lumbar vertebrae, and there was L1 vertebral collapse. And there was M-band on serum protein electrophoresis, which on quantification was 2.2 gram per deciliter. And on serum immunofixation, the subtype was IgG kappa. And serum free light chain assay showed kappa lambda ratio of 60.1. There were 45% plasma cells which were clonal on bone marrow examination, and FISH myeloma panel suggested translocation 414. And on the basis of the database, he qualified to be multiple myeloma with the ISS stage 3 and RISS stage 3. So my first question, I would keep it open to all the panelists. So how do we decide about the induction regimen in such patients, and how do we factor in the variables like risk stratification of the disease and transplant eligibility? Dr. Chirag, sir, I would request you to start with you.
So at least a triplet regimen, and I think RVD bortezomib Blendex is the standard, although I think a lot of people still use bortezomib cyclophosphamide dex. And I think majority of the clinical trials also use RVD as the standard of care. If possible, we would like to add daratumumab to this triplet. So for high risk, but even for standard risk, if it is feasible younger patient, then it is reasonable to add DARA. The idea being that deeper the response, better it is and more likely to be sustained. So if you can get MRD negativity, which increases with addition of daratumumab, and that leads to longer disease control. If the patient, this is mainly for transplant eligible patients. So I think for transplant ineligible, we may not go so aggressive with quadruplet, but triplet, yes. Unless there is a frail status, then doublet.
Thank you, sir. Any difference in opinion from other panelists?
No difference of opinion, but then I'd like to add 2 points. First is the risk stratification. It is going to revise in next meeting, IMWG, and most likely 414 would be out of the high risk the panel, and amplification 1Q and 17p deletion would be the major factors, along with complex cytogenetics, which would carry the high risk or ultra high risk subgroup. And having said that, for this particular patient, we can start with either triplet or quadruplet. But if the patient has more than 2 high risk parameters, then addition of daratumumab does not give additional benefit. So for those patients, as per the current, the latest data published, presented in ASH from Optimum trial, we may have to give a cyclophosphamide based or cytotoxic therapy that would take care of the ultra high risk characteristics along with daratumumab. So those are 2 points.
Prantar sir, anything you would like to add? So I think that it has already been very well summarized that the treatment paradigm of newly diagnosed multiple myeloma consists of addressing the important issues like risk stratification and transplant eligibility. And the goal of treatment is to achieve deeper remission, and that may translate into PFS and maybe an OS benefit in some patients. So let's move on to the second question. So it is, I would like to start with Dr. Pratibha. So ma'am, how frequently do you repeat myeloma panel in your routine practice? And do you perform PET scan, bone marrow examination on follow-up? And what is the role of MRD in your opinion?
Am I audible?
Yeah.
Okay. So in my practice, usually I repeat the myeloma panel after second month of induction, and depending upon the response, I will try to do it monthly or after the 4th cycle. So usually after the 4th cycle, depending upon the response, if we achieve the VGPR and CR, we go ahead with the transplant counseling. So that is the way we go ahead with the myeloma patients. Regarding the 2 questions, I will like to club them off, the role of MRD and PET scan and bone marrow examination. So in myeloma, for me, the MRD assessment in myeloma is still tricky. I totally understand that all the studies have said this, and I suppose there is nothing which is on the disagreement side, that MRD analysis in myeloma is going to be the next future of myeloma treatment, because that will actually help us to give patient a better PFS, and as you said, in overall survival benefit in some patients. But in case of myeloma, as it's a patchy disorder, unlike the acute leukemias, So you have to club so many investigations to actually get onto the MRD assessment, that only an NGS or only flow cytometry can't help you to get over the MRD analysis. You can club PET scan also, so that you can get a total assessment of what is the disease going on with. So, and the other thing with myeloma is that unlike AML or ALL, there are such a wide paradigm of treatments here available, that I think in future we will be actually analyzing that if we give a specific induction regimen, then this should be the cutoff of MRD, and this should be the duration after which the MRD needs to be done. So these questions are still blurry in case of MRD analysis. So I am not sure about MRD assessment till now in myeloma, although totally understandable that that has to be the next thing which has to come in myeloma. So in my practice, I do a PET scan because that's a partial MRD you can see before the transplant, before you go ahead with the transplant. So if you have an upfront extramedullary disease somewhere, to assess that off, a PET scan has to be done. But otherwise also before the transplant, I usually go for a PET scan just to see that the plasma cell activity, although it is totally non-specific, and only PET scan can't tell you that which stage the patient is going through now, because it has to be collaborated with the other parameters to assess what is going on in the patient and how better you can give the survival after the transplant. I usually don't do bone marrow examination near the transplant thing or in the follow-up case until the patient is having the symptom of relapse. So I usually don't do that.
I have a question here. So, the novel agents, immunotherapies, and the monoclonal antibodies are shaping up the treatment paradigm, and they are moving the paradigm. Now, when we are talking of an MRD, will there be a day that the MRD negatives don't go for a transplant? They go for something more novel, one of the monoclonal antibodies, and as has happened in many tumor types. So, will transplant be a thing which will not be applicable to everyone?
I think I had kept this question in the next slide for Dr. Chirag. Thank you, Dr. Ved, for
okay. Please carry on.
For picking up very very important pertinent question that we may come across in the clinic. Thank you, ma'am. So this patient achieved stringent CR after 6 cycles of VRD. He was MRD negative on bone marrow flow cytometry, and he was counseled for transplant, but he is a businessman, lives alone in Patiala. And as we come across this scenario with a lot of Punjabi families, and he expressed the desire to visit Canada to meet her family. So my question to Dr. Chirag is, do you routinely cryopreserve cells after RBD induction? What is your take on the ongoing debate regarding early versus delayed transplant? And as just asked by Dr. Ved, achievement of MRD negative status, does it affect your decision to proceed with transplant?
Right. So I think I would answer the questions more in what we do in practice, because I think there is a lot of variation. We don't cryopreserve stem cells for the long term. The long-term storage facilities in India are far and few. And in fact, recently when I checked for a patient who was interested in that, like more than 5 years, the answer was mostly no from the centers that I asked, or it was like we've rarely done that and not sure kind of thing. So practically, it is an issue that we don't have very long-term storage facilities. And so this would be useful only if you're talking of very long-term storage. On the other side, most transplanters experiences that they are able to get stem cells enough for one transplant, even at relapse. And so it is rarely a problem. So that's the practical side. Yes, ideally, if possible, like in the West, we would like to store for 2 transplants and keep it. early versus delayed, with the increasingly better treatment options, this discussion becomes more and more in the clinic that whether to do transplant right away, or for those patients who are very concerned, I am okay with delaying it, especially the educated ones who I believe that at least at relapse, they are more likely to go for transplant. Those who are older, around 60, I tend to tell them to go for transplant now, because the average disease control now with, say, VRD of about 9 months is 4 years, 4 or 5 years. So that means at that point, many of these people may become too elderly and may not be eligible for transplant. They may have developed some other medical illness, major comorbidity. So for those reasons, for them, early better. But for younger patients, it is reasonable to delay. In general, answer is to go for it, because it kind of, you are sure that the best possible treatment has been given. I also tell the patient that some percentage of patients go more than 10, 12 years. And that is like an operational cure, you can say. And that kind of quality of life is very difficult to get otherwise. Tandem transplant, rare, possibly for high risk, especially if they have not achieved the complete remission after the first transplant, some role there. Within the 4 to 6 months, if you can do the second transplant for them. And that may be an important option in India, where we may not be able to afford the multiple new options that are available, but on a practical level, they are not possible. And achievement of MRD negative status as of now does not affect my decision to proceed with transplant. In fact, it remains same as the discussion of early versus delayed transplant. And with MRD negative, also I tell patients that we can make this one-time negative MRD a very durable negative MRD by doing transplant, and you may be the one who will go to this operational cure. So as of now, that MRD negativity does not change. Or maybe in the other way, you can say that if the patient is still MRD positive, then the emphasis on transplant is stronger.
Thank you for your comments, sir. So to put things into perspective for the trainees over there, so this was the first paper on transplant, role of transplant in myeloma, which was published in 1983. The MEL dose was 100 to 140 mg per meter square. In the early studies, melphalan actually was able to quite easily beat down the chemotherapy, the previous chemotherapy regimens, hands down, and with the PFS, EFS, and some of the studies showing OS benefit. But over a period of time, with the introduction of novel agents, there was some debate on the survival benefit of transplant. And there are two recent trials, IFM 2009 and Determination, which have tried to address this question. IFM 2009 was carried out in Europe, and Determination was carried out in United States. And there was PFS benefit in both the trials, and there was no OS difference. So I agree with Dr. Chirag's comments that in the context of early versus delayed transplant, so one should actually realize that the window of transplant may be limited for some patients, especially who are close to their 60s. And the second important point is the benefit that we see in the trials reported from US and Europe in the form of IFM and Determination. So one of the reasons is that they have like good access to the post-protocol therapies. So that might not be the case in lower middle income countries. So transplant is a very effective and cost effective, I would say, tool to achieve a good disease control in the context of newly diagnosed myeloma. So moving forward, the patient was convinced by the family. He underwent transplant. Day 100 assessment was stringent CR, MRD negative, and he was counseled regarding the transplant. So my question to Dr. Ankit is, what is your strategy for maintenance therapy after transplant in standard risk versus high risk patients? And we just discussed this important question, the duration of maintenance. So what is your practice?
Yeah, so like we have already discussed, the currently category 1 indication for post-transplant patients, maintenance therapy for multiple myeloma is lenalidomide. That is proven by studies we have already discussed, IFM 2009, and along with that, other post-transplant studies. So even myeloma 11 study also had arm which looked lenalidomide versus placebo. So len 10 mg per day, 21 days a month, it is the standard protocol, and at least 3 years of therapy, 2 to 3 years of therapy I would like to give. If the patient is able to tolerate without significant cytopenia or without any other side effects like dermatitis or lower limb neuropathy. So those patients who are intolerant, for them, I would like to use bortezomib based on HORN 65 trial. So bortezomib every other week for at least 2 years. And coming to other molecules like ixazomib, there is a tourmaline MM3 trial which looked after ixazomib versus placebo in a randomized manner. So definitely ixazomib arm did better, but there was no benefit when compared with historical cohorts receiving lenalidomide. So only for those patients who are intolerant to lenalidomide and who are not willing to take bortezomib, being an injectable parenteral therapy, for those patients only ixazomib can be recommended as a maintenance. Daratumumab maintenance I'd like to give for those patients who have failed 2 to 3 lines of therapy, which included lenalidomide and bortezomib, and who are able to afford DAR-based maintenance for indefinite time. So at least 2 years of maintenance post-transplant monthly therapy. Duration of maintenance we have already discussed, that at least 2 years of maintenance, it benefits almost all cohorts. For those patients where MRD was positive, they will benefit for a longer duration of maintenance. Basically, we have not been doing MRD till now, and I think I would be speaking for all of us when I say that if the patient is able to tolerate len, I would like to maintain the patient on lenalidomide for a longer period, even more than 3 years also. So that is my take on that.
So thank you, Dr. Ankit. I would like to have your take on doublet versus single maintenance in high risk, and is it like what do you prefer, borti plus len or dara plus len?
Okay, high risk. So in high risk patients, those who have failed multiple line of therapy and had undergone transplant in a second or CR2 or CR3, or even without CR. So in those patients, DARA-based maintenance with lenalidomide, I would like to give. But apart from that particular subgroup, I don't yet use doublet or doublet therapy basically for maintenance. So even now there is no particular data, or the data is not matured to have a valid indication for a doublet therapy even in high-risk patients. So only those patients who had failed earlier maybe bortezomib and cyclophosphamide regimen, and those who are lenalidomide naive, in those patients I would use len plus dara, or I will also use dara plus cyclophosphamide in 1 or 2 patients who have failed 3 to 4 lines of therapy.
Thank you, Dr. Ankit. So, as discussed earlier by Dr. Anjali and Dr. Nitin alluded to it, so the role of continuous LEN was first highlighted by this trial, which was published in NEJM in 2012 by Philip McCarthy et al. And there was clear PFS difference of continuous LEN versus placebo. And this is actually one of the difference between the IFM 2009 and determination trials. So in determination, the LEN maintenance was continuous. IFM 2009, the LEN was 1 year maintenance after transplant. So we continue with the case. He undergoes the stem cell transplant, receives BOTI plus LEN maintenance because of translocation 414 being the baseline in the baseline marrow. And at 3 years, there was asymptomatic detection of M-band on routine follow-up. And 6 months later, he again presents with anemia, bone pains, and doubling of or more than 2.2 times elevation of M-band. And repeat examination shows 60% plasma cells. And now, in addition to translocation 414, there is del 17p. So my question to Dr. Pranthar sir is, how do you approach biochemical relapse in standard risk versus high risk patients? And how do you select the treatment regimen?
Yeah, thank you, Aditya, for that question, because, if you read the clinical trial data, their biochemical relapse is treated as a relapse, but that is obviously because, you're looking at certain endpoints. And if you look at the guidelines, including what we had framed initially for our image network also, we said that whether we should wait for clinical relapse. Now, the problem is that how long do you wait? So if you ask me, someone who is high risk in this case, I would be starting to intervene a bit early. What I usually do is a single report of an M-band coming in or a free light chain going high. I do not immediately start doing it, but then my monitoring, which is usually every 3 months, it comes down to every month. And meanwhile, I start counseling the patient that, possibly the disease is coming back. And if you get any symptoms, anything which you can't understand, then you please come to me earlier. For standard risk, again, it doesn't change much because our problem is, as you have said, that a significant number of my patients, even when I show them all the data, they are hesitant to undergo autologous transplant. So in those cases, I tell them that, this time you will need it. I'll go in for an induction consolidation and I'll do it. But based on a single biochemical parameter, I usually do not do it. I also look at the tempo of the rise of the monoclonal protein, be it in the SFLC or be it in the electrophoresis. And I also, if there are vague symptoms, if I suspect extramedullary relapse, then I undertake a PET CT at this point of time. So this is what I do. I do understand that, maybe in clinical practice, you can wait for clinical relapse, but sometimes the patients are anxious and sometimes I am anxious. So if I see that there is more than a twofold rise or the delta is high, then I might start treatment even when the patient has not acquired any symptoms. I would like to know the opinion of other panelists.
Thank you for putting it together, sir, and very beautifully, compiling your wisdom regarding the management of these patients. Views from other panelists?
Yes, I agree with Dr. Pranthar. I think you have summarized it so well how we do it in the clinic. For the low-risk patients, standard-risk patients, I wait till approximately an M-band of 1. So below 1, I am okay. Even more than 1 or a little bit over is okay. It's not a sharp cutoff. I see the tempo in that case. So, and if there are no CRAB signs, because even the official guideline is that you treat if there is a relapse with one of the CRAB. And we have seen that even after biochemical relapse, people can go on for 1 year or even longer. And you're just following them, the slowly creeping up M-band and 1.5 year, 1 year without any treatment. So that's a good time they can get without much, without added toxicity.
Thank you, Dr. Chirag. So in the interest of time, I would move forward. So this patient in second line received Darapom Dex and is in VGPR after 4 cycles. So we move on to with the second case. So she is a 45-year-old lady, a fashion designer from Chandigarh. She observed swellings on both sides of neck with 5 kg weight loss over 1 month duration. An excision lymph node biopsy revealed aggressive CD20 positive B lymphoma, and which was CD10 positive, BCL2 positive, and MYC positive on IHC. And FISH showed MYC and BCL2 rearrangement. So PET scan showed FDG-avid lymph nodes on both sides of diaphragm with the SUV max of 24. And there were FDG-avid foci in left breast and right kidney. LDH was elevated, her ECOG was 1, and IPA was 3. CSF cytology showed no malignant cells. So she was labeled as high-grade B-cell lymphoma with the MYC and BCL2 rearrangement. So I would open this case for discussion. So which imaging modality do you routinely perform in newly diagnosed high-grade B-cell lymphoma patients? Is there any role of baseline bone marrow examination in such patients? And what is your practice on doing FISH on lymphoma biopsy specimens?
So I don't do, I do routine PET-CT, not only CT scan in the initial assessment, because DLBCL, you can have very odd sites of disease. And I like to know before I start where all the disease is, so that in follow-up there are no surprises. But mainly for that purpose, unlike Hodgkin's, I think the role of PET is lesser. We don't change much treatment based on that. The role of baseline bone marrow, I don't do routinely if the stage is, whatever the stage is, and with PET being so sensitive that if there is nothing in the PET, then I accept it. And unless there is clear-cut cytopenia, then I would like to label it that this cytopenia is because of disease and not something else. So for that reason, I would do, if there are no cytopenia, I would not do bone marrow. And double expressor or double hit, I like to know by doing FISH, just because I believe in a little more aggressive treatment for double hit. Although I know that the science, the data on this is limited, and I think you will be discussing that treatment option later.
Other panelists, would you like to add anything to what Dr. Chirag said?
I more or less agree with Chirag sir. So we do routinely PET CT scan, and if the patient is sick, suppose the patient has GI bleeding with stomach involvement, or the patient is not able to go for PET CT scan, then we can do a plain CT scan of head and neck and abdomen, and then go forward. Same view for bone marrow examination. It is not essential. Only when there is cytopenia and we would like to rule out any other pathology, then only we'll do a bone marrow examination if the PET is negative for BM involvement. And for all patients, we like to do a complete workup with IHC as well as FISH panel for double expressor and double hit lymphoma.
So as discussed, so majority of the high-grade B-cell double hit or triple hit lymphomas, actually, they comprise about 8% of tumors with DLBCL morphology. Majority of them are GCB type. And the term double expressor is basically for expression of MYC and BCL2 on IHC. And the proportion of DLBCL cases with the double expressor phenotype is 20 to 45% in across various studies. So my next question is for Dr. Pratibha. So what is, ma'am, what is your approach towards baseline CNS disease assessment and prophylaxis?
Am I audible?
Yeah, yes, ma'am.
So for the baseline CNS profile access, to start with it, or the disease assessment, usually I follow the CNS IPI score. So if the patient is having a CNS high IPI score, or if the patient is having involvement of atypical sites like testicular, breast, kidney, adrenal, and double hit lymphomas in the very start, they have shown to have more CNS involvement, although I suppose that trial was a little bit questioned later because of the fish analysis, over analysis of the fish. So that is, I think it's more or less out of the thing, that that is not considered. And along with this, if the patient is having obvious involvement, like any isolated cranial palsy or something, so that's the thing which we follow. And in this case, I suppose that the CNS profile axis, before we start with it, I usually do an imaging and a CSF analysis. In practice, I have not started using a CSF flow cytometry, although I suppose that the paper which was recently presented in ASH, they have recommended that CSF flow cytometry will be a more sensitive method to see whether the involvement is there or not. So for sure that has to be involved at some point in the clinical practice, and if this point is well taken also. But for now, I usually do an imaging, and along with this, a CSF analysis based on these things. So for the profile axis, I suppose for the profile axis initiation, there has not been very well studied trial or very well randomized or conducted study, which has shown that whether the IT methotrexate is better or an IV methotrexate is better. So considering the testicular lymphoma, if I just make an exception of testicular lymphoma, in which the IT methotrexate has shown a benefit in the German trial, and it has been unquestionable. So in testicular lymphomas, I usually go for an IT methotrexate. But otherwise, if there is no such presentation and I have to give a prophylaxis, then usually I give 2 doses of high dose methotrexate after the completion of R-CHOP. And the point, I think, always remain here that the better we can control the disease, then of course that will translate into a better remission later on also, and less chances of relapse. And but again, the question remains that the CNS I
think we have lost connection with Dr. Pratibha. Other panelists, anything different that you practice routinely?
Other than testicular, we don't practice CNS prophylaxis. Neither IT methotrexate nor IV methotrexate. And there was a recent paper in Blood which showed that there is no difference by addition of CNS prophylaxis. So I think that remains a question that is still unclear whether anything needs to be done.
So as highlighted by Dr. Pratibha and Dr. Chirag. So this was the paper which was published in Blood in 2021 that assessed the outcomes of around 1,100 patients who received intrathecal versus high-dose intravenous methotrexate. And the difference in the CNS relapse rate was not significantly different. So it was like 5.4 versus 6.8%. So actually, the practice regarding the CNS prophylaxis is quite heterogeneous, and the jury is still out regarding what is going to be the standard of care. So, Dr. Chirag, how would you treat this patient? R-CHOP, DAPOC-R, something else? And what is your take on recent FDA approval of polatuzumab in newly diagnosed DLBCL and high-grade B-cell lymphoma patients?
So we use the dose adjusted EPOCH-R, and in spite of that negative trial from CLGB, where the double hit were very few, and the small data of multiple studies, some meta-analysis showing that maybe it is better. And as I've spoken to some of the international speakers at various meetings, also they kind of favor dose adjusted EPOCH-R. So I continue to use it in that group, although I don't push for it. So I would tell patients that if you can, this is better and I would like to. But if not, I am okay with RCHOP, knowing the limitations of the data. Polatuzumab, so far, no. The data is still, I think, early no OS difference and only PFS difference. So not yet. Maybe for somebody who cannot, tolerate vincristine upfront, some very small subset may be worth considering.
So as shared by Dr. Chirag, so RCHOP has been the king on the throne for last more than 20 years for the treatment of DLBCL. Multiple agents have been tried and tested in addition to the RCHOP, but no regimen has challenged it in last 20 years except for polatuzumab, which has shown a very small PFS difference at 2 years, and it was FDA approved last week with the vote of in favor of 11-2 in the advisory committee. So I think the time will tell whether the curves will separate more over a period of time. And this patient, we move on with our case. She received 6 cycles of RCHOP and IT methotrexate as CNS prophylaxis with each RCHOP cycle. And at the end of treatment, the PET showed dual 3 score. So, Dr. Ankit, what is your practice regarding interim PET and role of PET on follow-up in such patients?
So we routinely do a PET CT scan if the patient is planned for 6 cycles, let's say 6 cycles of RCHOP, then we routinely do PET scan at the end of 2 cycles, so interim PET 2. Having said that, there is a large meta-analysis available done on Petra study group. So they have examined more than, I think, more than 2,000 patients PET CT scan and compared to their outcome, specifically in DLBCL patients. So they had 2 parameters, 2 significant parameters, delta SUV and SUV max. And those 2 parameters were compared in respect to PET2 and PET4, interim PET2 and interim PET4. So interim PET4 was obviously more significant in comparison to interim PET2 with respect to better outcome, good prognosis. Delta SUV was the most significant parameter in interim PET4. But I would not like to do PET scan at a later stage and find out that the patient is not responding favorably, and we had already given 4 cycles before going for PET CT scan. So my clinical practice will remain as for now to do a PET CT scan at the end of 2 cycles and to check for the response rate rather than going for a PET CT scan after completing 4 cycles of treatment. So that is the first question. Second is role of PET CT scan on follow-up. Only in certain patients where I would like to, if the patient is high risk and interim PET was ideally 3, or the interim PET was positive and not completely negative. So in those patients, I would like to do a PET CT scan at least end of therapy, and routine PET CT scan on follow-up only in certain patients. Suppose a patient had low risk lymphoma and had a Richter transformation to high-grade B-cell lymphoma. In those patients, I would like to do a PET CT scan on follow-up to check for both high-risk disease as well as the underlying low-risk disease burden. So not for all patients, but in some subsets, I would like to do a PET CT scan.
So the timing of interim PET, any difference in practice, what other panelists routinely do in their practice? Chirag sir, Prantar sir?
2 or 3 cycles. not very strict about this, and not even strict about doing PET in everybody for DLBCL. So if patient is not affording or not willing based on the first bad experience of PET, I am very comfortable with doing only a CT scan interim. At the end, I like to document with a PET, but again, not very strict as in Hodgkin's lymphoma. And certainly no PET on follow-up. Very minimal imaging on follow-up. Very high-risk patients, we may do CT scan, but no routine PET scan in follow-ups.
Yeah, I agree with Chirag, and I think that, because if you're not doing anything by looking at the interim PET, then I don't do it. But if it's a high IPI and, I'm not sure what is going on, and I discuss it with the patient, and they also want to know from me that if I do an interim PET, what do I do after I see the report? So I think that is important.
I think that is very well summarized. So, so this patient again presented with the symptoms 2 months after the completion of treatment, and repeat biopsy confirmed that disease relapse. So my question to Dr. Prantar sir is, how would you treat this patient? Which salvage regimen do you prefer? And where do you put the role of CAR T cell therapy in such patients?
Yeah, I think this would be dictated by whether I have clinical trials in hand for relapsed DLBCL. If I have it, I always prefer to put them in clinical trials. If I don't have it, it depends on whether I will use RIs or RDAP as a salvage. And, the pharma showed that only in chemosensitive disease, I go in for an autologous. For CAR T, the problem is that, if you look at the Zuma and the other license and the subsequent licensed molecules, it is around 50% if I look at it. But fortunately, we now have 2 centers who are taking up relapse cases. So again, I would prefer these patients. Now, the question is, do I send them only at this relapse? This patient has had an early relapse. 2 months after treatment completion does not augur well for the outcome. So here, obviously, if there can be a CAR T therapy, I would do it, but there are some caveats here, depending on what is there and what kind of a co-domain means generation CAR T we are using. Still, I believe that whatever my understanding goes, looking at the international data which is being presented, that CAR T would possibly be used in first relapse slowly, depending on the availability. If I consider bispecific antibodies or like off-the-shelf therapies, I do not know exactly where I'll use it. If it's in a clinical trial, it's fine. Otherwise, obviously, it's difficult for my patients to undergo. So it's an open field in this case. But in this case, if you ask me, early relapse, try to give the best therapy. If you can't, use RIs or RDAP. And then if it's chemosensitive disease, you go in. If it's not chemosensitive disease, obviously you have nothing else but off the shelf or customized CAR T.
Completely agree, sir. Thanks a lot for very well summarizing the options for this patient. So we treated this patient with the RDAP. She went into remission, and she has undergone autologous stem cell transplantation. So I sincerely thank all the esteemed panelists for sharing their wisdom, and I hand over to Tejaswini. Thank you.
Thank you so much, Dr. Aditya. Those were some very relevant questions, and I thank our panelists for taking out the time to discuss with us how they handle these questions in their clinics. There's a question from the audience. I think Dr. Ankit Rayani could answer this very quickly. because it's a follow-up question to what he said. Are there any changes in hyperdiploid status in the future classification for multiple myeloma?
No, I don't think that would add to high-risk markers.
Right. Thank you so much. Thank you so much, everyone. I now request Dr. Nitin Sood to deliver the vote of thanks.
Tejaswini. So, I mean, I want to thank everybody for staying up so late. All the speakers, the experts, the panelists. We had a great discussion in the areas of lymphoma and myeloma. And we know there is a lot of progress in these areas. We constantly need such events to keep updated in this fast-changing world. And such events encourage us to look at the evidence very carefully and see how we can translate that evidence into our standard practice. So Dr. Tejaswini, my colleague, she's taken a lot of effort in organizing this. So congratulations for doing this. And finally, Intas to help us organize this. Until next time, thank you very much. And back to Dr. Tejaswini.
That's all, sir.
You want to close
I just want to thank all our viewers, all our panelists, and all the doctors who presented for contributing to this. Thank you so much.
Good night, everybody.
Good night.